My team's presentation is Reducing Travel Burden and Improving Access, Telehealth for Maternal-Fetal Medicine. We do have a disclaimer that telehealth services were funded by the Tennessee Department of Health, and our presentation does not represent the views of the Tennessee Department of Health. So the background to our problem is that travel burden, including long driving distances and the associated time cost and missed work, can delay or prevent receipt of high-risk obstetric care. Our analysis aimed to quantify the impact of MFM telehealth on patient travel distance across varying levels of maternity access after telehealth services were initiated at a perinatal practice. This map just shows the perinatal regions and shows that even though counties may have access to OBGYN physicians, they may not have high-risk specialists as easily accessible. This map shows our main site in Knoxville, as well as the two regional sites about 50 miles away that offered remote patient monitoring and telehealth services to patients in these regions. Our methods included a retrospective analysis where we categorized telehealth visits by county maternity access as defined by March of Dimes. Round trip travel distance was calculated for hypothetical in-person visit versus actual travel distance to the satellite locations. Total travel distance as well as average miles traveled per visit were stratified by maternity access level. Our results show that among 285 visits between initiation in April to mid-December, a total of 24,360 miles were saved, which represented a 77% overall reduction in travel burden. There was savings across all maternity access level. The greatest was observed among patients in full maternity access counties. Miles per visit average was also decreased. We did note that the highest baseline travel burden for in-person care was observed in patients residing in maternity care deserts. These graphs just show those details. In conclusion, using telehealth to deliver MFM services meaningfully reduces travel burden per visit across all maternity access categories. This represents substantial reductions in time, cost, and logistical barriers for perinatal patients seeking specialty care. In our implications for practice, we recognize that there are limited MFM services in the rural areas. Patients residing in the counties where the satellite offices were located were full access, so they had the greatest reduction in savings. We also recognize that smaller changes in low access and maternity care desert counties may reflect a need for even more broad expansion of services, and these are planned in the future. Thank you.